You're here because you care about creating a Transylvania County where people can get the help they need to be happy and healthy and productive, and you're here among friends, so welcome. My name is Kristen Gentry, and I'm the Program Director for the CARE Coalition of Transylvania County. This organization is a group of folks who are dedicated to community-wide collaborations that address substance misuse. So we work prevention through recovery. So before we get started, I just want to make a few housekeeping announcements. Following the panel, we will have some opportunity for questions, and then we will break bread together. So following the panel, feel free to get yourself something to eat. We have a lot of resource tables and folks from a variety of Western North Carolina agencies that are here. So learn from them, see what they can offer, connect, and it's at that time after you eat and meet new people, you can leave at your leisure. We hope you stay, but we don't have anything planned after we eat. So we encourage you to connect with as many folks as you like. I would like to take a moment to recognize Teresa Radford, our Community Outreach Coordinator. So she's responsible for community outreach and education on the issues of treatment, harm reduction, and recovery. She and one of our coalition teams has worked through the summer to put this event on. So if you are part of that coalition team, please raise your hand. I'm looking at Brittany, I'm looking at Jamie, where is Angie? And then some of our panelists as well, Lori. Thank you all so much for your work to getting this event together tonight. I think I got everybody. Oh, Kimberly, there you are. I couldn't see you from my point of view. Thank you all so much. And so without further ado, I would like to introduce our moderator, Amy Upham. Amy is the Executive Director of Eleanor Health and is a healthcare manager and innovator. She has a history of successful program design, implementation, and evaluation in behavioral health and in the public health field at large. She has led several initiatives with outcome gains at both program and population health levels, including overdose prevention. She enjoys working alongside clinicians, social workers, first responders, physicians, peer supports, and others in creating innovative solutions to seemingly intractable problems. Amy received her Master in Public Health from Lenore-Rhine University in 2019, and she's happy to be here today for this inspiring event. So please join me in welcoming her.
Thanks everyone, so glad to be here. So glad to be among these panelists, and I'm gonna let them introduce themselves. So can we start with you, Lori?
Hi, my name is Lori Ashenfelder. I'm with BJ's Wish. We lost our son in 2021 to fentanyl toxicity, and I'm here to share our story.
Thank you, Lori. Dr. McDowell?
Hey, my name is Susan McDowell. I'm a family practice physician at Mayheck up in Asheville. I've been specializing in substance use disorders since I started there in 2019, so I do kind of half-time patient care and a half-time education around opioids and other substances. And I have a brother who has a long-term recovery for substance use disorders, so that's how I got kind of interested in this field.
Thanks so much. Philip?
My name is Philip Cooper, and I'm a person in long-term recovery. I'm a Western North Carolina native. I work full-time for the Land of Sky Regional Council, leading a team of certified peer support specialists who are all in recovery from addiction, who are assisting people as they get out of treatment and go back to work.
Thanks so much. Patience?
Hi, my name is Patience Camp, and I work for SAFE, domestic violence agency here at Brevard, and I'm the community outreach specialist and volunteer specialist as well. I've lost my brother and my niece to drug abuse.
Thank you, Patience. Taylor?
Hey, I'm Taylor Ludwig. I'm a licensed clinical social worker and addiction specialist. I am the Associate Director of Integrated Care for Behavioral Health with Blue Ridge Health. And I also have some lived experience. I was born addicted, and addiction has definitely been a a part of my family's story. And yeah, I'm really passionate about breaking that cycle and helping others break it as well.
Thank you, Taylor. Thanks, everybody. So today, talking about substance use and stigma, obviously we're going to have some hard conversations, and but also, as the title says, hopefully you'll leave here with some hope. So the first question, Taylor, I'm going to throw this to you. Can you explain for folks just the basics of substance use disorder?
Yeah, so put me on the spot first. So, when we're talking about substance use disorders, that sounds really clinical, and I like to just start with the first word. So, what is a substance? In the context that we're talking about, a substance is anything that we're putting in our body that changes the chemistry of our body in any type of way. Substance use is whenever we are actively using whatever that substance is, putting it in our bodies. And then when we're talking about a substance use disorder, it's continued use of that substance despite negative consequences that it's had on your physical health, that it's had on your life. So I really like to take a moment and think about substance use in the context that anything that we're putting in our bodies is a substance. So like over 60% of Americans drink coffee every day. I am 100% one of them. I drink coffee way more than I should. Also get headaches if I don't drink coffee. So I'm chemically dependent on caffeine as a substance. So yeah, substance use and rising to the level of a substance use disorder happens whenever you're meeting clinical criteria that is really affecting various areas of your life and causing some dysfunction. So there are a lot of people who use substances, and it doesn't necessarily mean they have a use disorder.
Yeah, that makes sense. Thank you so much. Anybody else want to chime in, add anything?
I think when we think about it from a medical perspective, as a physician, really did a great job kind of outlining what I would say as well. But I think when I think about it, when I'm talking with patients, when I'm going over it, I'd say it's a chronic relapsing disease, just like diabetes, just like hypertension. It's something that we're trying to control. Sometimes it's going to ebb and flow. Sometimes it'll be well controlled. Sometimes it won't be. Sometimes people will need medication. Sometimes people will need lifestyle support. Sometimes people will need both to kind of help them achieve their goal to manage their disease as best as they can.
Yeah, it's important to add things. Okay. It's a pretty simple question. They get more complex as we go on. Philip, I'm going to put this to you because this event is so much about stigma. What does stigma mean to you?
So I have on a bracelet I got from Next Step Recovery. Susan Stater is the ED there. It says recovery heals, addiction kills. So if addiction is the murderer, I would say that stigma is the co-defendant. Stigma was the one that went and got the pistol for it. You feel me? It's stereotyping. It's taking away a person's rights. It's dehumanizing a person, judging a person, looking at a person less than, not even with having hope for the person. So I would say that stigma are all those things.
Yeah, I've never heard it put that way. That's a good metaphor. Others, what does stigma mean to you? Lori?
For me, it was a lot about staying in the shadows, staying in the background. Don't talk about it. It's a very difficult topic to talk about when you're talking about substance use and the effects that it has on your family. So you tend to stay isolated a lot more than you normally would. And that's what stigma, I think, does to me so often.
Yeah, the isolation piece. Absolutely. Others, and this can be a very personal question too, if you want to share something about how, what it means to you in your life. Go ahead, Taylor.
Taking my clinical hat off, the stigma, I feel like, is what ruined my family when I was growing up. There's all of these barriers to accessing care. Growing up in and out of foster care, there was not the level of awareness or resource that there is now. Testing positive on a drug screen, your kids are taken away from you, and there was it took away hope. So stigma would really it killed that hope. And, you know, so whenever my mom would use, instead of being able to go to a social worker, going to whomever their support person is and saying, hey, I slipped up, this is what happened. There was fear of consequences. So there was not that, you know, partnership in treatment or treatment available really back then. So I think stigma has affected families so deeply it's even hard to describe.
Yeah, sounds like taking away someone's humanity. Yeah. Anyone else want to chime in at all? Yeah, Patience.
I would like to say that stigma coming from a basis of fear and misunderstanding and the way that people portray things that they see maybe on television. Something for me personally is, you know, if they see a show or something on television that portrays people that use drugs this way, or, you know, how their household may look and things like that, and then how they're going to view me or my family, because being in a small community, everyone knows everyone, and they're seeing this person that is using, and then turning to look at that family and say, well, it must be the family's fault, or, you know, they're not doing something right. And a lot of times that's not the case. You know, so just the way that things are portrayed, stigma plays an awful role in that.
Yeah. Yep, the media definitely creates and feeds off of that, for sure. Dr. McDowell, how have you seen stigma affect people who use drugs?
Good question, thanks. I was just thinking about it as we were sitting here chatting. My boss, Blake Fagan, who most of you guys may know, he's one of the guys at Mayhem who's gotten a lot of the stuff started in addiction treatment. He has a thing on his wall that says stigma kills people. And I think you said, Phil, it's maybe not the murderer, but it's definitely the co-defendant when we think about it. How I've seen it affect my patients is definitely stigma, I think, is a delay for care for people to come in when they do. I think they should have probably come in a lot sooner, and when you get to talking to them, they've experienced a lot of stigma in a lot of different settings, whether that be in their church community, in their family community, thinking it's a moral failing. When I think about it in the criminal justice setting, it's pretty bad, and then even in the medical setting, I feel like we have not done a very good service to our patients in the past. With giving them a lot of stigma when they come in. What we know is that only about 20% of people that need treatment get treatment. So 80% of those people are not, right? And a lot of that probably has to do with a lot of stigma and a lot of a word that I associate with stigma too, which is shame. And that's just something that I think keeps a lot of people out of seeking recovery. I work in what's called Project Care Out, which is for women with substance use disorders who are pregnant or parenting for the first year. I guess pregnanting could be a word too, right? I'm making words up here. And so we see a lot of stigma around that too, for mothers who are using. And so I think a lot of them will delay their prenatal care and not come in, thinking that they're going to be shamed when they arrive at our office, and but they don't have that experience. But I think 10, 15 years ago, like you were saying, someone in your family experienced more stigma than they would now. So I think stigma, creates barriers to getting care, creates barriers to coming in for regular care. And I think there's even stigma in the medical community. I was chatting with Kayla on the way down, and there was a study that went out. I'm gonna get dorky with numbers here for a minute, so let me flip this over. There's a study that came out in 2019 where they surveyed a bunch of primary care physicians through Johns Hopkins. And 33% of providers still did not believe that medication for opioid use disorder was effective. And that's a big problem that we have. If the evidence-based treatment that we have that is successful is only known if you're a glass half full person, by 67% of people, glass half empty, 33% of people still don't know. And so we're trying to create a lot of covering those gaps here at Mayheck locally to try to get providers trained, but we need to do a better job as providers, and I think there's a lot of places where other folks can community, like what the work you're doing, the work you guys do to help fight stigma. That was long, sorry.
No, that's okay. Is that 33% of providers, you said? Ooh, okay. Medical providers.
And then I just wanted to add too about stigma. It comes in all forms. So if, when I think about folks that are struggling with addiction, I think about them as a person in their environment, in that community with the people around them. And a big barrier too is stigma for recovery. If you're someone that is trying to get into recovery, it's really changing everything potentially about your life. So you may have friends or family members that are still engaging in substance use that may, shame you, or, oh, you think you're better than us now. Like, I hear that all the time from patients, and that is probably one of the biggest factors to return to use and not staying in recovery.
Thanks, Taylor. Other folks have anything to add about how you're seeing it affect people who use drugs today? No? Okay. Patience, I'm going to have you lead this one off. What does stigma look like for individuals who are part of a historically marginalized group? And that might include folks who are Black, Indigenous, people of color, LGBTQ, those who are incarcerated, survivors of domestic violence, et cetera, et cetera. How do you see that kind of intersection?
Thank you. So in the marginalized communities, and I'm just gonna read this because I wrote it out because I wanted y'all to hear it clearly. In marginalized communities where there has been, where there has continued to be a lack of support to assist with many of the challenges, including substance abuse, individuals have continued to do as has been done for generations. What that means is, I talked to my grandmother or my mother, and they said, well, my mother did it like this, and this is what we do. So I'm gonna explain a little bit more of what we do. Where cultures teach being strong and not seeking help with private matters, rather handle all the things yourself and to suck it up and deal with it and move on. That was something that I've been taught to do in my personal life. And so I can imagine someone that is facing a substance abuse issue, how they deal with that, Some reasons behind this is that many marginalized groups do not have the same opportunities and resources, have not been available to an equal degree. And even more so, it would be difficult to express their needs to someone that would not be able to relate on a cultural level or possess compassion of wanting to understand that culture. So, in all, it's a tough area, and just not having a way to deal with a lot of things on a lot of levels, and just substance abuse with that, having not knowing where to go or who to talk to or where to even start that conversation. So these are some of the challenges that are in many different cultural areas.
Yeah, excellently put. I heard three things there. I heard there's sort of an extra layer of shame and secrecy, access to care, and then when you get the care, is it culturally competent? Is that what I heard? Yeah, that's a lot. Yeah, other folks.
But of course, I couldn't wait to answer that one. So growing up, I always wanted to be a gangster. And in the hood, you sell the dope, you don't do it. Like, we might commit all the crimes in the world, but bro, you better not be getting on that mess. That's how crazy the stigma is. Even for the gangsters that are committing crimes and living a criminogenic lifestyle, you better not use the dope, right? And so for me, what I still see to this day, especially in the Black community specifically, is people who are not proud to be in recovery. Like, I still know some brothers, even when they do get clean, they don't be want nobody to know that they go to meetings. When guys get out of prison, one of the first things I do to them, like before I even assess their needs, I let them know who I am. I let them know I used to do dope. I let them know that I'm in recovery, I've been in treatment, so I can normalize that. Without meeting with somebody that's done been in their shoes before, a lot of times they won't even admit that they have a problem. And that's something I've been raving about for the past couple of years, because the diagnosis is dependent upon the assessor. And if you don't trust the assessor, then you won't be honest with the assessor to get the diagnosis. And in this day and age, if you don't get the diagnosis, you might not get the resources. And so, like, showing up and recovering out loud is definitely important when we look at what's going on in the Black community. And we have some funds that came from the state, and we have this initiative called Voices of Appalachia. Shout out to Dogwood and the Department of Health and Human Services. But what we're doing is we're addressing that access by way of getting more certified peer support specialists and community health workers, because there's a difference between the community health worker and peer support. See, in the Black community, we got some trusted leaders that might not have ever done drugs before, but they're a trusted leader. And you might feel like you can open up to them. And so that's what we're trying to do, especially in the rural areas, is get more community health workers that can be a point of contact. And it's been helping. Like, we've been getting some folks into treatment from Rutherford County. We've had to send them to Synergy. We've been have a good relationship even with Partners Behavioral Health now. And that's what it's going to take is like getting more people who are from these communities to be those points of contact. And we might never, in the Black community, I don't want to be so pessimistic, but recovering out loud might not happen for us for a while. I mean, the rappers are making it cool to use the dope now. When I was growing up, it was cool to be a drug dealer. Nowadays, these rappers are talking about, Percocet, Molly Percocet. The next thing you know, you're on a drug that you having a physical detox from. Thinking you're just cool like a rapper. So we're gonna have to have some ninjas. I like to think of them as ninjas, some Power Rangers. Out in the community being those heroes, and they might have to keep it on the low, but we got to make sure the people that's using know who they are and who to call when it's showtime.
Yeah, such important work. That's excellent. Thanks, Philip. Anyone else can speak to the folks who are more on the margins and what that might look like? Taylor.
As a clinician, whenever anyone comes to see me and it's their first visit and we're trying to establish rapport, I think it's really important, first of all, to recognize power differential in the room. I don't view it as me having any power over a particular person, but I have to acknowledge that the clinical diagnosis that I come up with can really affect someone's life and their ability to access care. And also have to recognize differences and speak it. I feel like we've got to do better about speaking about differences because they're real and it's okay that we're different, but we have to at least acknowledge it to even start having that conversation.
Yeah, right on. Absolutely. Yeah.
I just wanted to say thank you for what you just said. That meant a whole lot. Talking about the differences and knowing that it is okay to talk about it. I don't look like this gentleman next to me, nor do I look like this young lady next to me. And it's okay to be aware of that.
Yep. Yeah. So why is this issue important to you? And I'm gonna ask Lori this, but definitely, absolutely, everybody can answer this.
For me, it hit home, hard. July 16th, 2021, I came downstairs to wake my son up for work. And I was too late. He was gone and there was nothing I could do about it. I've heard a few people say, we need to say it out loud. And that is something that's really important. We need to talk to each other. We need to know what's going on in each other's lives. So many people around my son knew what was going on, but they didn't talk to me. They didn't talk to him. They told him they didn't like what he was doing, but nobody did anything. It's not their fault. He was going to use, and he was stuck in a situation that he couldn't find hope. We went to detox, and he was sent home. Didn't have him. And the state he was in, he would have been happy to sleep on the floor. It was a whole lot better than where he was sleeping. For me, it's important that we have these conversations. It's okay to say the word fentanyl out loud. It is killing our kids. We have a whole generation that are dying from it. Substance use disorder, it's okay to talk about it. We all may look a little differently, but so many have experienced it, yet we don't talk about it. We talk about it in our small little groups, but we don't talk to the people around us. We don't talk to our friends. Our families don't know what to say. They don't know what to do. We've got to find a better way of treating those around us that are suffering. I could go on. I'll give somebody else a chance. That's why it's important to me.
Thank you, Lori. Thanks for sharing your story. Yeah.
It's important to me because, like I said before, I have a brother who's in long-term recovery, and it's been a part of my life since I was 14, even before. So, and I grew up in the rural part of Appalachian, the southwestern part of Virginia. So it's, I lost a basketball teammate to a heroin overdose and a friend's brother to a fentanyl overdose recently. And it affects us all. And like Lori said, if we don't talk about it, it's gonna fester inside of us, and we're not gonna let other people know our story. We're not gonna bring it into the light so we can talk about it more and address it. Things are in the dark, they're gonna remain in the dark, and we have to talk about it. I can kind of call it a silent epidemic because we're not talking about it that much. But, you guys are here, you can go out in the community, you can talk about it with other folks that are around you. I live in the west part of Asheville, and I start sharing my story with the community, with our friends. I have a friend who, there's a syringe access program right near us, and he was saying derogatory things toward it. And that's a time where you can just say, hey, you know what, those are people seeking help. This is people that are looking for help, and like just that one interaction maybe will change 4 more interactions later. It's like that kind of ripple effect that will hopefully happen. So if we can leave here and do just those conversations, like that'll help for sure.
Yeah. Pressing against the norm. Thanks.
Why is this important to me? I'll just say it's my purpose-driven life. Some of y'all may have heard of the book by Rick Warren. I was lost. I was using the drugs, I was selling the drugs, and I didn't see a way out. And recovery gave me a whole new life. It gave me a whole new mission. I'm a man of God, so I'm one of the Jesus people. Some folks that even look at them hands, okay, Jesus people. I see y'all. They got proud of me, Holy Ghost. But like when I think about it though, like even with my friends I have in the church, not all of them even understand my condition. And most of my friends are in recovery. Gene back there works with me now. He was my workout partner in prison, and now we're on the outside trying to change the world. Herschel just came home. I call him Uncle Herschel now. You know what I'm saying? Mostly everybody that I deal with is in recovery, and we have found a purpose in helping others. And it's pretty cool now that people are seeing lived experience as an expertise. You know what I'm saying? And it's not guaranteed that I'm going to stay clean forever. Don't get it twisted. I don't want y'all to think I'm cocky like it can't happen to me. Because it can happen. I've seen people with more clean time than me go back out and die because they've been abstinent for a longer period of time. So one false move, so I could be dead. They lacing everything with fentanyl. They cutting everything with fentanyl right now, But what I will say is this, man. Today, I bet y'all won't get high. I bet you that. And it's been working one day at a time for over 13 years now. So that's why it's important to me.
Thank you, Paul. Patience.
My brother died from using crack cocaine. His daughter, she was shooting up pills. However that's done. It was difficult to watch them both go down. She watched her father. I watched her father, my brother, and watched her. The last thing that happened was she went to jail because she was
was found in a restaurant here, and the police was called out. They took her to jail. She called me to bail her out. I did not, because I wanted to get help for her. We talked during that time. She asked to come home. Home was my house, even though this was not where she grew up, but this was what seemed familiar and someplace where she could get understanding. So I was looking, searching for some type of help for her to come home, but to come home clean. Someone bailed her out, and she lost her life. Not only this, but my daughter's friends in school, there was another child that was close to her. She lost her life. And it's like, you know, I look around and I was close to this individual as well. That hurt. And after all the hurts, I have to ask myself, what can I do? Where does this stop? When does it get better? But sitting here is not going to help it. So this is why it's important to me, because I want to see people healthy. I don't want to see people judged. I don't want to see people laughed at or people turn their head because of whatever's going on in their life. But let's be that loving, supportive community, the one that we talk about, the one that we talk about when we go to church. You know, we love each other at church. Why can we not love that individual that's out there struggling? That's why it's important.
Powerful. Thanks.
Substance use has affected my life from when I was in utero. I mean, my mom's addiction, it throughout my childhood took everything. I was never a child. I never had that, never had a normal childhood. And roll that in with a lot of trauma, domestic violence, all of that perfect storm. It really affected me at my core in a way that has always been hard for me to describe. I just have always felt a fire in me, and I'm so grateful for that, because I knew what was happening around me was not okay, and I did not want that for myself. I didn't want that for my little brother. And the system failed me and my family so horribly, and I was angry for a very long time, and I'm still angry, and I think anger is okay. It's one of those emotions we say is not okay to have, but I'm still angry. I'm still angry at the failures. I'm still angry that addiction is taking people's lives. But I don't know, I decided to try to make a difference in the system, even though I've been told that I couldn't, that I'm just one person and that it doesn't matter. But every single person that I have an interaction with, it matters. And my philosophy for life and for clinical work is, if you're alive, we have something to work with. So we have to keep people alive long enough until they can get help.
That reminds me of a famous saying in harm reduction: we're not enabling people to use, we're enabling them to stay alive. So, patients, back to you, the family. What can family or friends do right now if they know someone who's struggling?
Can I turn the page? 'Cause I wrote this one out too. So I asked this question to my daughter. daughter's 18. I just wanted to get her feedback to see if she knew, as a young person, what to do to get help right now for somebody they asked. She told me that, I'll say I have 3, and they have all grown up in this community, but her answer was, do not say the obvious things such as, don't do drugs, or just quit. I mean, I don't know, for anyone with any type of things, like if someone told me just to quit coffee, you know, I'm not hearing that. Like, you're gonna have to tell me the reasons and how and the steps to take to get there. And also not ignore the signs of substance abuse if you see it. So for me to answer that, from what I heard from her, is listen. Whether it's a friend or family, listening often is the first step in interacting with someone who may be facing a substance abuse crisis. Sometimes they just don't want to hear anything you got to say. But sometimes, you know, if you just sit down and say, okay, let's talk. Let them talk. Don't say anything, because, you know, as a parent, I've had to learn that myself, just talking regular conversations with my children, but hearing what they have to say and knowing that I have really heard what has been said. And if someone confides in you and shares their challenges, be prepared by educating yourself with the resources that are available within your area. My daughter said, send them to the hospital, you know? And this is from an 18-year-old. So where would you go? She said, the hospital, great resource, you know, because if someone is ready to go at that point, the hospital has resources to get them to the place that they need. She also stated the DSS, which has our health department within it. And so, well, actually, I'll state it frankly like she said, the place where you get condoms. And so, yes. And so that would be the health department. And the health department would have those resources because obviously they teach about reproductive health and things like that. But, you know, children nowadays, they're really frank and they're really honest, and, you know, they mean business if you talk to any of them. And they're a lot more active than what they used to be. And so making them aware of the places that if a friend comes to them and gives them or confides in them, that they can share those places where to go. And so, like I was saying, being prepared by educating yourself with the resources that are available within your area, whether it be the primary care practitioner, a mental health provider, hospital, or community leaders such as your local pastor or domestic violence or homeless agency. They're all starting points. And I say domestic violence agencies because a lot of times those fleeing domestic or sexually violent homes have a substance abuse history. Working in a DV agency, I see this more times than I would like to see. A lot of times the substance is forced upon the victim by the abuser, and also substances are used as a way of coping with the pain, coping with life, coping with your children that you're having to take care of, or coping with the abuse that comes along with being abused. Even used during or due to the emotional and mental aspects of codependency, because valuing the approval of others is far more than valuing self, your own self-value. So, when it comes to domestic violence, sometimes you'll choose to do what looks right in the eyes of your abuser over thinking it through and not doing the drug. So, that's all I have to say.
Yeah, thank you. Thank you. I feel like that's a good segue into what other resources are there in Transylvania County? If anybody up here knows, patients mentioned the health department, the hospital. Where else can folks go in Transylvania County if they have a substance use condition? Taylor's smiling.
You can come to the Blue Ridge Health Office. We have a lot of offices spread throughout Western North Carolina, and one of the things I love about working for Blue Ridge is that we're a federally qualified health center, so we serve people regardless of ability to pay. We're never gonna refuse treatment for anybody, and being able to treat the whole person in front of us. So, you know, a lot of times people will come in and they're coming in for counseling and they're trying to seek, treatment for a substance use disorder, but they also have lots of medical conditions or various other things that they've kind of neglected because of the lifestyle they've been living. So yeah, we are right up the road.
Excellent. Excellent resource. Others? I'm going to mention my agency just really quickly, Eleanor Health Foundation. We don't do treatment, but we do help folks with some of the social determinants of health, so some of their financial needs, maybe housing, transportation, that kind of thing. So, I'm not trying to plug myself, but we do serve Transylvania County, so I want to make you all aware of that. Anybody else?
I think statewide too, you can think about the North Carolina harm reduction site is great. They have a lot of
Yes.
resources, and I think is that where you find the county by county guideline for people who use drugs and the resources that you?
The Drug User Resource Guide, yes.
Is that on there, or is that DHHS?
It's DHHS's, but it may be, yeah, if you just Google Drug User Resource Guide North Carolina, it's county by county. It's awesome.
Yeah, it's really cool. Came out like last year or so.
Yeah. Yeah, great resource. Yeah, patient.
Also, I would say your local practitioners as well. A lot of them are knowledgeable about the life-saving treatment medications that are being used at this time. So that is another great resource to have, just to know if you want a doctor. Either they are themselves or someone that they know is qualified to help with treatment.
Philip.
Yeah, so this is gonna go to the family members. So if you have a family member that is struggling with addiction, my prayer for you is that you would also take care of yourself. There's support groups that are specifically for people who have loved ones who are struggling. And I know it's hard. I speak at funerals. I have ashes in my office. You feel me? So if you do have a loved one, you know, you have Celebrate Recovery, you have CODA, you have Narconon, you have Refuge. I mean, there are many different support groups, but please take care of yourself, because you can't pour from an empty cup.
Yeah, well said. This wasn't on the list of questions, but I'm actually curious, does any agency here carry naloxone? Okay, Blue Ridge does? Great.
And we're also, we also prescribe MAT, so medication assisted treatment.
Okay, awesome. And patients to the safe place?
And we have Narcan in case of a accidental overdose. We use Narcan. So Narcan is something that will revive someone until emergency assistance can get there. I'm sure if you call some of the agencies, you can have this on hand at home as well.
Yeah, awesome, so important. Yeah.
And your primary care physician can prescribe it for you on behalf of one of your family members, and it should be covered with your copay at your pharmacy. There's also a standing order at North Carolina Pharmacy that you can go pick up Narcan. Not all of them will honor that, but not all of them will honor that, but the ones that do. And for people with unmedicated, it's a $4 copay, but the pharmacies have been told to waive that and give it to folks
in Buncombe County, Walgreens is really good about it. I don't know about Transylvania County, but they're a great pharmacy to get it from. Thank you. So, where can we find hope in all this? Philip, I'm gonna get you the hope shot first.
I mean, look at yourself. Just look around the room. Turn to your neighbor and say, neighbor. Hold on now. I know I'm in rural North Carolina now. Y'all, turn to your neighbor and say, neighbor. I am a change agent. Now turn to your least favorite neighbor and say, look them dead in the eyes and say, I am a change agent. These people in here sacrifice time to come together to talk about a similar cause, right? As long as the ties that bind us together are stronger than those that would tear us apart, guess what? All will be well. So surround yourself with people that's on a similar mission. Everybody ain't gonna be on the same page with you, and it's okay, let them be over there. But when you do find somebody that got the same passion, that cares about the same things, those are your allies. We don't have time to waste on people who are not with us at this point in time. Too many people are dying. So we find hope from each other. We pour into each other's cups. We know when each other are tired, and we know we gotta say, hey, Herschel, ride with me. I know your mama just died. You feel me? You coming with me to this event in Transylvania County. We're gonna kick it for a little bit, bro. That's how we keep that hope alive. But we gotta stay close and we gotta stay proximate.
Amen. Yeah, all right.
It's gonna be a little tough following that. But we do find hope, as Philip said, by coming together. If we keep coming together, we keep talking to each other, we lift each other up when we're down. I have gone through the worst year of my life, but I have found so many people that have stopped and just talked. And they felt where we were. They took the time out of their day to spend a few minutes, and they listened to what I had to say. Losing a child, no matter what the age, my son was 31. It didn't matter. He's still my baby. But we find hope by loving the people around us, keep talking to each other, don't shut each other out, put the stigma away. Because DJ used did not make him any less than or more than. He was somebody that was stuck. But he had a huge heart. He had the best laugh. He gave great hugs. We have to keep hope, because without it, I crawl in a corner and just stay there. And I can't do that, because people around me mean too much to me. So keep talking to each other. Thank you.
Thank you, Lori. Hope. Who else has got hope here?
Hope to me is just having faith that change is possible. And I think that in the professional communities, we've had a really negative narrative over, the last few decades around, the things I learned in school was the age you started using substances was the age you're stuck at. And I was like, so, in utero, I'm stuck there? Great, awesome, cool. Or, getting beer in my bottle when I was 2, I didn't think I was still stuck there. But luckily science is catching up to what we know, and that change is possible whenever people are heard and loved and supported. And, science is supporting that now. We have brain studies and scans and all that fancy stuff to show that we can change those pathways in the brain. It is possible, and that gives me a lot of hope.
Right on. Good.
I have hope being here with all you guys. Hearing your story, you went to Congress. That's awesome. I mean, all these changes. It's really cool. In the medical community, I have hope because I get to work with residents and medical students every day. And the way that they view substance use disorders is much different than the generations of physicians before me, and the way they talk about it in the first language really gives me hope that things are changing, and that, I gave you that terrible statistic earlier, so I'm gonna give you a little bit better one. So 20% of attending physicians are thinking about treating substance use disorders versus the survey went out and 50% of residents. We're not there yet, but we're getting there, right? So people in training are more likely to go out and help treat folks with substance use disorders. And I'll tell you guys, just go out, and I think the one thing I've learned from all this work is to be curious and non-judgmental, and just listen and learn and share your story.
Excellent. Patience, did you have an addition?
Hope for me is education, or educating. I feel that the more that we educate ourselves, that way we can educate someone else. And also just being fair, I spoke up earlier. You never know, it could be your neighbor, your anyone, person sitting next to you, it could be. If they turn to you for help, educate yourself so that you know where to send them for the proper resources so that they can begin their road.
All right, y'all. What a great panel. Y'all give me hope. The people I work with every day give me hope. And the fact that there's so many people here, in a rural, smallish county is a lot of hope for me. Now we're gonna move to questions, and I don't know if we have a microphone to pass around, do we? But I think we can all hear each other. Does anybody have questions for the panel? Yes, sir, in the back.
I've been listening to, first of all, I appreciate you guys humbling yourself, coming here talking. It means a lot. I've been listening or reading the slides behind you. And so you're in crisis. You go to detox. You go to rehab. You come out of rehab. Now what? Can you talk a little bit about some practical things other than the counseling and the support, which I really believe in? The counseling, very important. The medical help, important. But can you talk a little bit about, he was talking about the need a bridge. What does that bridge look like? When you're coming out of rehab, you've been clean for a while. What will have caused you guys to get on the right path quicker?
Anybody?
That is such a good question, and in full transparency, I think it's a gap that we have in the services that we offer. There are people that they go get help, and then what, right? Like, they're going back to the same environment, living in the same homes a lot of times, in the same community. Just in the experience I've had with patients, I've seen the best outcomes whenever they were able to remove themselves from the community, and that's really, really hard though. And we have to acknowledge it requires resource, it requires money, and willingness to cut ties with people a lot of times they've been surrounded with their whole lives. But I think, we have to think about the person, we have to think about their environment and who they're surrounding themselves with. People, places, and things are a lot of times what contributes to people returning to use. Yeah.
Money for what?
Money for what?
You ask that you need money, you coming out and often with nothing but the shirt on your back. And you're asking you need money. Money for what?
A lot of times housing, the housing crisis is really bad right now. A lot of times people will try to access housing through a halfway house or something of that sort. And sometimes there's substance use going on in those recovery houses. But it requires resource and money for almost everything.
Yeah, Philip.
Yeah, so thank you for asking that question, and it is definitely a very important concern, especially when I hear it coming from a rural area. So I live in Asheville, North Carolina, just to be clear. Asheville is, if not the most recovery-friendly city in North Carolina. We have people coming from all over the United States of America that come to Asheville specifically for recovery. Many come to retire for the breweries as well. But when I think about why people came to Asheville, my brother, they came because they needed to relocate from where they were from because the area didn't have the recovery resources that were needed. So the question that I ask folks whenever, because we go and speak in treatment centers, somebody had asked me about our program and how we engage with folks. So we're in ADAC, we're in Swain, we had October Road CASP. These are all the state-funded programs. So the people, like you say, that have just a shirt on their back, those are our peoples, right? I mean, we can serve the rich folk too. But what I want to say is that it's up to the person. It's up to the person. Because see, when the pain of remaining the same is greater than the pain of change, that's when we change. When we know good and well, like a lot of times when folks say, I ain't going back home because I know I can't get right there, they're ready. Sometimes the family want them to come back home. Why you don't want to come back home? But the reality is some of that same family is saying why you can't come back home. They've been enabling them anyway. And they need their own help. They can't get their own help because they're busy enabling. Because they don't know, they love them, but they don't know how to love a person struggling with addiction. And so to answer your question, bro, the reality is where the person is at. Is that person, at what stage of change is that person at? And hopefully while they're in treatment, they're working with a counselor and a discharge planner that's determining where's the best place for you to go after this. Because there are places to go. There's long-term programs that are free. But a lot of times people don't voluntarily want to go to those longer-term programs unless they've been beaten, unless they hit a true rock bottom. So there are programs that are in existence, and as she mentioned, sober livings, but we need more. Just to be honest, just so y'all know, when people talk about opioid settlement dollars, when I go up in them meetings, I'm always talking about recovery housing. I got a call from somebody in ADAC today. He's on methadone. And just so y'all know, there's different, everybody who in here knows there's different pathways. There's different ways to recover, right? You can do abstinence-based, you can do medication-assisted treatment. Whatever, pick your choice. But the reality of it is, there's not enough housing. I mean, you can attest to this. There's not enough housing for the people that's on medication-assisted treatment, right? So whenever it's time, they start wanting to talk about that money. That's what we need to start demanding. And we got to demand it, y'all, because they're making decisions about people with addiction without people with addiction at the table, right? And so they'll continue to put resources out for stuff that, as my mom would say, that don't mean a hill of beans. You know what I'm saying? So we got to make sure they know the housing piece is where the resources need. Because we got tons of medication. There's several providers in here right now that can get you harm reduction. They can get you medication. But can you get the housing? So that's the demand right now. And I'm letting y'all know on a regional level, the demand right now is for recovery housing. And we need more housing for the people who are on the medication. Because the medication is readily available now coming out of ADAC. Just so y'all know, even out of prison, we got people that come out, just want to stay at y'all house. Got out of prison, he got straight on MAT. Straight on MAT. But we don't have enough housing for them.
So you got housing.
Okay.
Now what?
Well, then you got to have a program. You got to have accountability. You have to have other people that come on alongside of you to do life with you. The opposite of addiction is what? Is what? Say it loud. Connection. So these folks have to have connections with people who can hold them accountable, who knows them well enough to say, bro, you look like you off right now. What's going on with you right now? Something ain't right. Talk to me now. Talk to me now. Open up. I ain't gonna leave you alone till you open up, right? You have to have that connection because we can't do it by ourselves. Isolation is addiction's best friend. And stigma's the co-defendant. You know what I'm saying? So we gotta make sure that a person has that recovery community. So if they're going back to an area, let's say the Graham counties, the Swain counties, a lot of times those folks want to relocate. The Cherokee counties, they want to relocate because they don't have a meeting that they can go to every day of the week. And your counselor and treatment is telling you, we need you to do outpatient in 90 and 90. Where you going to do 90 meetings at? Where you going to do 90 meetings at? So they have to relocate a lot of times, and it's okay. But that's the answer to your question, my brother. You have to have community because the opposite of addiction is connection.
Yes, Carrie.
Taylor and everyone else there, can you speak to the idea of full diagnosis and mental wellness and addiction? Because I think those two are disconnected when they need to be
Yes. So, it's kind of, I hear people talk about it like what came first, chicken or egg situation, like was there trauma and that ended up, resulting in substance use, or did using substances cause people to be in risky situations, which resulted in trauma? Even if you take the trauma piece out of it, we're talking about genetics and predisposition to have mental illness, and there's not a clear answer, and I think we have to look at the person in front of us and what is going on with that person. A diagnosis is for insurance companies. It can be very helpful whenever we're talking about a course of treatment. It helps give us some parameters, but truly diagnoses, and the DSM-5 was created for insurance companies. So let's be real, we gotta get back to the person in front of us. And if you're looking at the person in front of you and you're really listening to them, I think you're gonna hear probably both. There's probably mental health stuff going on. It doesn't necessarily have to be schizophrenia. It could be they're going through depression or anxiety, or they do have this very long, what we often see, a very long history of trauma, and then we're looking at generational trauma and cultural trauma and just all of that put together. We cannot address substance use without looking at mental health. We can't.
I'm gonna throw in a statistic there real quick. 81% of women and 69% of men with opioid use disorder were physically or sexually abused as children. So thank you for bringing up trauma. Sir?
So this question is for Taylor and Susan, and it's related. Susan, Taylor, do we have enough MAT available in our county, and the behavioral health that goes along with it? Are people being turned away from Blue Ridge, or is there plenty of treatment available, and are they getting the amount of treatment that they need? And then maybe for Susan, if you don't have that, why do providers, why are they reluctant to take this on? Is it something that's very difficult, or are they just unfamiliar with it? Are the patients hard to take care of for practitioners, or is it just a myth that they seem to be busted?
Can you repeat the question?
You want me to repeat it for you, or?
Yes, go ahead.
Okay. So the question is there enough resource in our community to prescribe MAT? Are we turning away people at Blue Ridge? And if we are, then what is the reluctance of providers to prescribe MAT? Like, what's the barrier there? We certainly don't have an abundance of providers. I think everywhere in the nation is short-staffed, and we can definitely feel that when it comes to providing medical services and mental health services, but we are not turning anybody away that is showing up at our clinic asking for help. We're prescribing for people when it's clinically appropriate. I think there's a shift that's happening in the way that medical providers are being trained. When I was really, focused in on addiction recovery, it was very different the way that we would talk about a MAP program. So a traditional MAP program, it can be very difficult for people to stay in recovery. Waking up at 5 o'clock in the morning, and trying to find a ride, going down to their local clinic, they gotta have $15, $20 to pay the doctor, who's probably also selling things shadily on the side. I mean, that was the type of stuff that was going on for people that were trying to get help, and that has significantly shifted. So at Blue Ridge, a lot of our medical providers, they are practicing from the philosophy that addiction is a medical disease, and they don't necessarily have to engage in this very extenuous program to receive the medication to save their life. So I think we're experiencing a big shift in the way we're even administering MAT, and then any type of requirements around that. Honestly, I'm a little bit torn on it, because just coming from a mental health perspective, I do think that it can be really hard to stay in recovery if you don't have that level of support, but we're not gonna force anybody into counseling. You have to be ready. So if getting MAT, and if that's where it starts, for someone to stay alive long enough again to get the help that they need, then I'm here for it.
You asked about the, why more prescribers don't prescribe MAT, I think is if I'm summing it up the best I can. And I think one thing that I will, say in regards to you too, Taylor, is that we're trying to make this shift from calling it MAT to MOUD, which is medications for opioid use disorder, right? Because I don't call diabetes medication DAT, it's not diabetes assisted treatment, so even that's a stigma, right? So we're switching it on to medication. So you may hear me say MOUD or MAT because there's kind of two things. So you may be aware, you may not be aware, but it used to be you have to have a this thing called an X waiver to be able to write buprenorphine, which doesn't make any sense because it's safer than the OxyContin that people used to write all the time, right? If someone went out and they took 90 OxyContin that I wrote today, they would most likely overdose. If they went out and took 90 buprenorphine, they would most likely not because it has the way that it works biochemically. So anyways, there's all the stigma, even at the federal level, right, of we have to go through this special training. So I think the Trump administration, at the end of their administration and the Biden administration kind of tuned it up a little bit. Basically, you still have to get the X waiver, you have to apply for it, which is an extra step, but you used to have to do an 8-hour course if you were a physician and a 24-hour course if you were a nurse practitioner or a PA to be able to write that medicine, and that's been done away with. So I think that change we'll see kind of hopefully make it easier for more prescribers to write. But I think honestly, a lot of it has to do with stigma that's in the medical community and why more people don't write. And so we're trying to change that by more education and just being more transparent. At the end of the day, it's not hard to treat someone, right? It's just like I'm a primary care doctor. I can treat you from time of year 0 until 99. And so in my practice, I see patients for their MOUD medication, I also see them for their diabetes and for their COPD and all the different problems that they have, and we're able to do whole person care compared to what Taylor was saying before, where it was this silo where MAT was here and this is part of your life, but diabetes and the hypertension, everything else is over here. So there's a shift now. I think it's gonna take a few more years, but more and more prescribers are learning how to prescribe. Every medical student, right, is getting trained in addiction treatment. And so by the time they graduate medical school, they'll have probably 100 times more knowledge than I did when I graduated 10 years ago, 12 years, something like that. So.
Awesome, that's great. And that's at Mayheck, right? The students at Mayheck.
Oh no, that's across the state.
Oh, cool.
Yeah. So every medical, so we had a grant through the Department of Health and Human Services to train all the medical students across the state. And so Duke, Wake, Carroll, UNC,
all family medicine residencies as well as
the medical students.
nursing, nurse practitioners, urology, all of the training has really penetrated all the residency programs across the state. And it's now this is the 5th year of this initiative, and it's being integrated into all the residency programs.
Awesome. Other questions? All right, well, I think do we have time for 1 or 2 more questions? One more, we'll do one more. I don't know who to.
You should arm wrestle.
You're in front, so I'm just gonna pick you up, so sorry, you in the red.
I just thought when the other question came up about the what now,
Uh-huh.
I was expecting to hear, I realize this is clinical and medical and medication things, but I was expecting to hear about NA, AA,
Mhm.
Al-Anon. I was sort of waiting for that,
Sure.
because that's a really what now
Mhm.
answer.
Yeah.
Well, I'll say this, so as an active member, right, the traditions is what I try to respect, and so I do my best not to promote a specific fellowship out of respect for the traditions, but I would love to come up here and just say that that's the answer. But in this day and age, man, we've had so many people die, there have been more pathways that come alongside, and there's even been some beef amongst the different pathways. Like you may have seen some beef between the 12-step pathway and the medication assisted, how did you say that? MOUD, not a memorandum of understanding, but the MOUD. So you see, like, it's been some beef, my sister. So I'm glad that you said it out loud. But me, I respect the traditions, but I'm definitely a 12-step guy. But a lot of times when I've been in these kind of spaces within the past couple of years, I've even had a hard time myself being like one of the few abstinence-based recovery folks, because there's so many people at the table now you know, and if you've been around for a while, then you might understand that there's been a shift even with the definition of the word recovery. So I just try to respectfully say things like the opposite of addiction is connection, and you have to have a group of people holding you accountable. Maybe a sponsor, maybe a support network, maybe a home group, right? I'm with you, I'm with you, I'm with you.
All right, well, thanks everybody so much. There is food out there. Thank our panel. Give it up to them. And wish you could stay for a